And because it's short and it's focused on compliance issues that most healthcare professionals don't think about, I thought that I would include this. So this gives you a sense of the rules that are incorporated in this document and that have to be adhered to by every hospice agency in the country, every certified hospice agency. Okay, so let's talk a little bit about hospice. What I want to do is I want to talk about the history a little bit. Then I want to provide you with an overview as someone who is on the medical side might see it. So I'd like to try to highlight some really important take-home messages, again with the goal of thinking about hospice in the service of palliative care, specialist level palliative care at the end of life. Then I want to talk about the role of the physician, and then I want to talk about the economics. And then if we have time at the end, I will walk you through the COPS and point out some of the phrases and descriptions that provide the substance to these rules of the road. Okay? Any questions or comments about the goals, the agenda? Okay. So, as I talked about before, hospice grew up as a separate healthcare system in the United States, and it was finally passed into law after about 10 years of work in about 1982. And then subsequently was expanded from Medicare to Medicaid. And the Medicare and the Medicaid hospice benefits are basically identical. And these are federal benefits that are in federal statute and set up a separate healthcare system. The system was set up as the first managed care organization in the United States, meaning to say that the system was set up so that patients who were eligible would be certified as eligible, come into the system, and then the agency taking care of them would get a per diem payment for the care of the patient to provide a range of services. The agencies would take on full risk. So this is called full risk capitation in 2010. Back then, I'm not even sure that that's how it was called. It was very innovative, but today we would call it full risk capitation related to the terminal illness. The hospice benefit covers payments only related to the terminal illness and only for those patients who are eligible by the regs and elect the benefit. Now, there's a very important issue here, and that is that it's actually an entitlement. The way it is structured in the federal regulations is exactly the way Social Security is structured, and Medicare, the full range of Medicare services are structured. This is an entitlement. So the Medicare hospice benefit is a Part A benefit. It's a Part A benefit like dialysis, like rehabilitation services. It's a Part A benefit, and it requires patients to turn over the Part A benefit to which they're entitled with respect to the terminal illness to the hospice agency. Okay? So that's a very important point. So that means that every patient in the United States, every person in the United States who is 65 years old or is receiving Social Security benefits, receiving Medicare as a result of disability, for example, any one of those patients and patients who are indigent and are receiving Medicaid can elect this benefit if they meet the medical eligibility. And in electing it, they sign an election of benefits document called an EOB. And by signing an EOB, they turn over their Part A benefits to the hospice agency, which then bills for those services. They're only with respect to the illness that's designated as the terminal illness. So if a patient has another illness, that means that the reimbursements for care, hospitalization, for example, or other services will go through the usual Part A and Part B system, and Part D system for drugs, right? But if it's related to the terminal illness, everything will go through the Medicare hospice benefit. Okay? By the way, another epiphany for me in my youth, like 3-4 months ago, was the recognition that physicians who peremptorily decide that patients are not ready to hear about hospice are actually denying an entitlement from a patient, and it is an egregious act comparable to a social service worker, for example, not informing a 65-year-old that he or she is entitled to Social Security benefits. So the decision that's made to not tell a patient or family that this entitlement exists because of a view that they're not ready to hear it is actually, to me, it's an act of commission. It is a decision on the part of a health professional that denies an entitlement from a patient. So if you're going to deny a patient's knowledge about an entitlement, you better have a very, very strong rationale for that. And as you all know, by this point, there's so much misconception about the hospice benefit that you have to be concerned that patients are being denied information about this benefit because of a misunderstanding about what it offers. Okay. So, and then the other last prefatory thing I want to say about the entitlement issue is that people who now work in hospice are, many of them, at least the leadership nationally, is striving very hard to reconceptualize the goals of hospice from the concept of the good death or the good death at home to rather the concept of providing comprehensive care for advanced, serious, and life-threatening illness. So if you think about the benefit as an entitlement program established by the government for the provision of comprehensive services to patients with advanced illness, it becomes much clearer that everybody with advanced illness should at least know that this benefit is out there. And it should also become clearer that patients don't have to accept that they're dying. They don't have to accept that they have no more care for their illness. We'll talk more about that in a second. They don't have to accept anything except to be clear that they become eligible for these services provided by the government at no cost to them at a certain point when they're eligible, and that can be explained to patients. And then this is an entitlement program to provide comprehensive care. For a while, those of us who are interested in advocating for hospice, advocating for palliative care, thought that the words palliative care would take hold in our culture in the United States, and that it would become much easier to talk about hospice because hospice would be explained as the means to provide specialist-level palliative care at the end of life, or specialist-level palliative care when the disease reaches a certain point. But unfortunately, there doesn't seem to be much movement in establishing an understanding of palliative care either. So we have trouble with words in the United States, and hospice is clearly a very stigmatized word, and palliative care seems to be stigmatized to a lesser extent, but around the same set of issues, right? Death and dying are very poor social marketing terms in the United States. They just don't get people turned on, and so hospice's link to death and dying has really been a big problem. Okay, so let's talk about eligibility. What's the eligibility for the hospice benefit? Does anybody know? Beyond being eligible for Medicare or Medicaid. Or you can be eligible for the hospice benefit under various commercial carriers, but they're set up completely separate from the federal benefit, right? So if I have Empire Blue Cross Blue Shield, there's a hospice benefit under there. If I'm sick, I should read my policy. I shouldn't assume that all of the benefits that flow from the government under the Medicare and Medicaid hospice benefit are included in my Empire Blue Cross Blue Shield policy. But if I am eligible for either Medicare or Medicaid, then I might be eligible for these benefits if I have what criteria? Anybody know the criteria?
Advanced illness, where you can, under normal circumstances, you can kind of certify that patient has life expectancy less than 6 months.
Right. So one issue is that there has to be a terminal illness, and that terminal illness has to be deemed by two physicians, one of whom is a contracted physician, one of whom is an employed physician of the hospice,